Thank you everyone for joining us today. My name is Yasmin Jayasinghe. I'm the Director of Oncofertility at the Children's Hospital in Melbourne. And I'm really delighted to be hosting this webinar today. Thank you, Mahmood, for the invite. So we do have a little message for you at the start of the webinar, as per usual. It will take about 45 minutes with 15 minutes for questions at the end. And we'd really appreciate your mic being muted and your camera off throughout the webinar. If you've got any questions, please post them in the chat and we'll open up the chat at the end of the webinar. It is going to be recorded and it's going to be uploaded to YouTube afterwards. And thank you so much again for joining us. So I'm really delighted to be introducing Dr. Astrid Ahler to the consortium today, and I'm really excited to hear her presentation. So Astrid is a senior fertility and sexual health specialist, and she ran the fertility preservation program at the University Hospital and University Children's Hospital of Basel for over 10 years. She's a board member for the Swiss Fertility Preservation Group, Fertility, and she's contributed to national and international bone marrow transplant guidelines for fertility preservation in children. She's part of an interdisciplinary sexual health clinic in Basel, and she runs workshops for the European Society of Sexual Medicine and also for adolescent young adult organisations in Switzerland. She's particularly engaged in the sexual and reproductive, She's particularly engaged in the sexual and reproductive health of cancer survivors. And we were so happy to have her in Melbourne during a 6-month fellowship at the University of Melbourne, and she contributed to developing online tools for adolescents, young adults on the topic of sexual health and fertility. In 2021, she founded the Just Ask Us project, and I'll leave it to Astrid to tell you all about it. She certainly was an incredible breath of fresh air when she came and visited us in children. I'm sure you'll find the same during her presentation. Thank you. Over to you, Astrid.
But yeah, thank you. Thanks a lot for this very lovely introduction. And I really, first of all, have to really say thank you for the invite. And I feel very honored to give this presentation, especially after I did attend for the first time your meeting last year. And I was amazed about the quality and the overwhelming welcoming culture of the US guys. And so I'm very pleased now to be here. And I would like to talk about Just Ask Fertility, Sexuality and Body Image, the unmet needs of young cancer patients. So the content of my presentation, I would like to start with showing you why ticking the box by preserving fertility will not ensure the psychosexual well-being ever after. And then I would like to take you on a metaphoric journey showing you why body image and psychosexual well-being is not a luxury, but essential for the quality of life in our survivors. And then I would like to come to the role of the healthcare providers and showing you the attitudes and barriers towards sexual health communication, and give a suggestion how potentially could do better. And finally, also give you introduction into my Just Ask Us project. So I think this slide probably you have seen very often already. So this is showing that we did improve over the last 30 years the treatment of cancer, which is leading to around 80% survival rate in cancer patients. And especially in the young adolescent and adult group, we have now 1 out of 530 young adults between the age 20 to 39 is a survivor of a childhood cancer. So this is the reproductive lifespan. So, but you know, as well as me, that the treatment has the side effect, especially is gonotoxic, especially the treatment that did lead us to this rise in survival rate, which is namely the bone marrow transplant. So when we now have a look on the attitude towards the importance of fertility, on quality of life, we know from the adult cancer survivors, and now more and more also in the adolescent and young adult setting, is that 80% of our survivors want to have their own biological children. And there is a decrease in quality of life in case of fertility issues. And I think this statement is very, very strong. So infertility is perceived as fatal as the cancer diagnosis itself. So, you know, the referral for fertility preservation is improving, especially in the adult setting. It has become a standard of care, but again, mainly in adults. And even also in the pediatric setting, I think it is of growing importance and now included in international guidelines. And especially now, it is more and more becoming aware, especially we can now offer also treatments to the prepubertal patients. But this is, I know, an older study, which is already 10 years old, from the Netherlands, showing that out of 1,200 referrals, there is only below 5% the age group under 20 who have been referred. But the data, unfortunately, still are the same, at least when I was out talking to the Fertility Protect, to the German fertility preservation group. It is the same. It's not as much as we would like to, but I think it's of growing importance and awareness, as I said. But I think this is just one part of the story, because what's then? So why do we want in the first place to preserve fertility? It is to ensure an improvement of quality of life, as I said, because it is an important factor. But then what about the survivorship? So we know that the utilization rate of frozen gametes is still unknown in the children and young adolescents because of the young age. They are not old enough to really come back. But what we know from the adults is there is only a very, very low utilization rate of cryopreserved sperm, about 10%, and even lower in oocytes, or even ovarian tissue, which is about 6%. So why is that? Of course, it's difficult to really assess the cause because people are moving, they are lost from follow-up. But so in the best case scenario, they would have conceived naturally, which luckily still happens. Or in the worst case scenario, it's a death or recurrence of the disease. But then there's still a great black box. So they might decide against having a family or lack of a partner, because what do we know is that our patients, so which means the children, adolescents, and young adults, they experience difficulties in building romantic relationships, are more often single, socially isolated, and suffer from sexual dysfunction compared to peers. But before you can even think of having a partner or having children then potentially with your partner, you first of all need to feel good in yourself before you can even think of opening up towards a relationship. So, and then the body image comes into the picture. So I think the composition of the body image is like body and mind are inseparable, like yin and yang. When you do not feel good in your body, you will not feel good in the mind, and the other way around. But what exactly is the body image? It is more than just what we see in the mirror. What we see now in the painting of Magritte is there's also this transparent aspect. So it's more how you feel yourself within your body. And what we ask in the therapeutic setting is, do you occupy your body? And by thinking of what else do we occupy, houses did come into my mind. When we now think that we are all born as houses, then the facade is given by nature, whether we like it or not. And it can be a more modern version or tiny little hut with a big roof and tiny little windows, or a more simplistic version. Or if you're lucky, perhaps you're born as this castle. But tastes are different. And this will not all our life stay the same, because we are all exposed to weather and atmosphere conditions and permanent changes. So to a certain degree, we can fix damages and restore, but to a very high degree, we just have to live with it. But we're not living alone in this world. We are living and are surrounded with neighbors. And so, of course, everybody of us would love to have this crowd cheering and saying, wow, how beautiful is this house. And I think we are all afraid of having these guys standing in front of our houses saying, oh, wow, how miserable does this house looks like. But what they all have in common, they think how beautiful it must be or how miserable it must be to live in this house. But this is another story. Because when we have a glance through the window, even if this beautiful castle, then it might be empty because we are not coming fully furnished into this world. So we are, of course, stuffed already with some furniture, but the decoration process in the inside is ongoing and independent. And what I mean is that everybody can make a castle in the inside. And when it comes to stormy weather conditions, where do you want to get sheltered? In the first beautiful looking house, or would you rather look through the window and when you see this cozy little chimney, perhaps you would prefer to sit in front of it to warm up? So what I'm about to say is, I think the main task is to make us feel at home in ourselves. So how can I now get the sexuality in the picture? So then I was thinking about the Garden Eden, because the Garden Eden is as promising as sexuality is. So there are rumors that they are milk and honey running down the rivers and everything is beautiful and they have big fruits and everything is great. But the same with sexuality, the reality is different. So especially in the beginning, in puberty, it is a construction site. And perhaps then you will start and seeing this little buds growing on your trees, and then you get curious and you start, okay, wow, but I'm not sure what this will become one day. So perhaps you will look over the fence to your neighbors and said, okay, wow, he had that or she had that as well. And now by time, it did become a beautiful cherry flower tree. But what if you will discover these creepy flowers in your garden? Would you also go around and asking others, what do you think of it? Knowing that perhaps you're the only one? But this is a pity because this is a desert rose. And if you do not have anybody who would tell you that you just have to rose it, then you will not know that this will become perhaps a even more ordinary, extraordinary flower than all the others have. So what I'm about to say is the size and the plants in our garden might be given by nature, but it is in our hands to make us feel at home in it. And if you do not have a green thumb or you're not interested in the garden, that's okay as well. But it is in your hands to make the best out of it. So when we now think we have our beautiful house, did build up and water our great, beautiful garden, then cancer comes. For me, cancer is like a big tsunami wave. And as I said in the beginning, luckily, we ensure that we do not lose the entire house anymore, but it does not look the same anymore. And I think this is absolutely understandable that the impaired body image due to physical side effects of cancer treatment is one of the main concerns in our young survivors. And it, of course, does influence self-esteem and intimate relationships. That's why it does completely make sense to me that these survivors, they reach sexual milestones later in life. They have a higher risk of sexual dysfunction. And over 50% even have ongoing problems 2 years after the diagnosis. And females are twice likely as their counterparts to have problems. And what is very interesting, I think, problems are not related to poor general health specific type of cancer or its treatment. And of course, there's a fear of being less valuable dating partner, and they struggle in building and engaging a close and romantic relationships. So what are the risk factors? So I think which patients we especially have to keep in mind who might develop these problems. And I think this, again, is kind of logic, because those, of course, with already a low self-esteem and negative body image in the first place, and also the highly neurotoxic and gonotoxic treatment, especially when it comes to early ovarian insufficiency and the peripubertal age. And why is that? The pubertal development, as you know, might be interrupted, very often it is, during the therapy, but the sexual feelings and desires stay the same. But of course, there's a lack of opportunity to discuss. They are separated and isolated from peers. They are perceived as children rather than sexual beings. And there's a lack of intimacy because we need to go and rush into the rooms now and then. And so there's not really time and space to discover the sexuality. So they're kind of behind all the others. And even if we know that now, we know by several publications that the adolescent and young adult survivors, they consider sexual health of one of the most important aspects of quality of life. And the majority, they want to have a sexual health counseling. But in contrast to the reproductive and fertility discussions, 75 to 95% never had a sexual health discussion. It has never been addressed. So why is that? What are the barriers? So the healthcare professionals, the clinicians' own embarrassment and fear, they do not want to invade into a more private setting, and perhaps also fear of legal consequences, especially when they are younger. The belief that sexuality is defined solely as sexual function. That's why boys are more often asked than girls, because it's easier to ask if they have erection. The belief that sexuality is not part of the presenting problem, which is namely cancer, and also the clinician's own lack of training and in assessing sexuality. And on the survivor side, of course, we all know it's not easy to talk about sexuality. So there is, of course, an own discomfort and embarrassment. And also a main problem is the time constraint during the medical visit. As we all know, it is not a lot of time to discuss any other thing than just the medical problems or not being asked, and the hope and helplessness towards possible existing solution of that problem. And what do they tell us? And I think these are three very strong statements. I got this slide from Sharon Bober, who was also involved in the research. So first is a discomfort. I don't want to make my provider uncomfortable, which is interesting, I think. And also the initiation. So I think my provider should bring it up. And I think this is very strong as a validation. I'm worried that there are so many other things that seem more important. It's going to seem like I'm not grateful to be alive. Again, this luxury problem associated with sexuality. So during my stay with Yasmin and team, there was this Oncofertility Summit in 2019 at the Royal Children's Hospital. So we wanted to assess more the potential barriers and attitudes towards the topics of body image and sexuality. So there were 60 attendants taking part in this survey running through Cult Campus. Half of them were clinicians, the other half were nurses and others like psychologists. So the first question was, how do you perceive the importance of body image and sexuality in your patients? And it was, for me, it was very, very astonishing that 98% did perceive it at least important to even very important. And how do you rate your degree of knowledge related to these topics? And in 72%, they considered it to be moderate to non-existing. And how do you rate your confidence in consulting with your patients about these topics? And again, it's 70%, they consider themselves to feel not at all confident or moderate. So, and how often are you involved in talking with cancer patients about these topics? And in 55%, they were not involved or not very often involved. And so when you have these discussions, who raises the topic? Well, in 22%, it was not discussed at all. And it's only in 9% the patient did bring up the topic. So what are then the obstacles to start the conversation? And here are several answers possible. And only in 5% there were not obstacle at all. And I think it was very interesting to see that, of course, time constraint was also a very big barrier and lack of knowledge. But the winner was the lack of further information and supportive tools, which also makes sense because many of the clinicians that I did talk to, they consider it very important. But then I said, okay, but when I will bring up the topic and there is a problem, And I do not know what to say because I'm not a sexologist. I'm overwhelmed, perhaps. It would be really useful to have something that I can say, okay, listen, I have something that I can at least give you so that he's or she is not stuck in the conversation. And that's why I think this would be a very good step forward. That's why also we did ask in case, so if they would like guidance, information, support, would they use it and would they like to have that? And it is in nearly 100%, they would really like to have it. So what are the next steps? So what we know from the survivor side, they would like to have a direct communication from the clinician. They would like that the clinician would initiate the conversation, and they would like to have an ongoing conversation because it's our patients, they develop over time and they might not have a problem in the beginning, but perhaps with time, they will then face problems. So it is important to bring up the topic in a regular basis. And they want to have a time alone with the clinician and especially normalize the conversation. That is kind of everybody can have a problem. It is not that particularly you are the only weirdo who perhaps will face the problem, and to individualize. So, of course, it's all easy to say, but we all know there's not a one-fits-all strategy because we are different and also our patients are different. So from Anand, from the sexual therapy setting, he developed the Plicit model, how we can lead or engage in such a conversation. So, and this starts with a permission. So listen and enable a discussion. You can say, okay, many survivors or many cancer patients have problems in this field. What about you? So it's kind of an open invitation. And then very often it's just myth around. So it's a lack of information. So it's important to already just give information, clarify the situation, educate and demystify. And then it comes to the specific suggestions for the patient, which might consist in hormonal therapy, behavioral interventions, or mindfulness training. And only then is the intensive therapy necessary, which might consist in a psychotherapy, surgery, or sexual therapy. And I think it is kind of striking that Anand could show that in 90% of his patients, he could already help with the 3 first steps. What I'm about to say is you do not need to be a sexologist to already help and improve the situation. So what could we do? A suggestion is that the aim would be to demystify the Pandora box. I think by enabling everyone to talk about sexual issues, but with respect to their own personal comfort zone. As I said, not everybody is a sexologist and you might not feel that comfortable, but still it is important to at least start the conversation and offering the information in a routine way to facilitate the discussion about it. So it's normal for you and normal for the patient as well. And then most importantly, I think it is really develop information tools for the patients and the healthcare professionals so that you are not stuck in the situation, but then know where potentially send the patient to. And therefore, I think it's important to define clinical pathways and referral strategies. So what could be the next steps? So there is still a lack of evidence-based sexual health interventions targeted especially for pediatric survivors. But luckily, there's a growing attention paid to these issues. And one of, I think, a beautiful and promising approach comes from Sweden, where they did screen survivors for sexuality and fertility-related distress. And if they did show a distress, then they could attend a 12 weeks online tool. And then they could already show in the preliminary setting that this would have an impact and improve the situation. But now they are really starting a bigger research setting, which has been published in 2019. I'm very, very keen to see what this will bring. So, but coming to my project, our project, so the approach from Sweden and from others is for patients who already did develop a problem. So, and our approach is that we want to prevent that they will even develop a problem. So we want to be there when they feel alone, when they have questions, and then start already to support them. So the aim of the project is to reduce and prevent fertility and sexuality related distress. And we want to fill the gap of unmet needs in the field and offering a non-judgmental space to discuss intimate topics, and also lower barriers and facilitate discussions of healthcare professionals. So who's behind the project? I did start the project in 2021, thanks to a grant that I did get. And it was very important to me that we will have more insights of and different point of views, all from people who are dealing with cancer survivors. So we have a survivor, we have an oncology nurse, pediatric and adult, we have a psycho-oncologist, and of course a lot of reproductive endocrinologists and sexologists, and also gynecologists for adolescents. So what we do offer is, one is a follow-up consultation so that you really can see the patient, which I did start already in 2017. And now we also have a platform to ask questions around the topics, an interactive website with information, videos, and podcasts. And we are now developing also workshops for survivors and also communication workshops for healthcare professionals. And we try to do this as much as we can via co-design, so that we really also implement survivors to tell us and show us and guide us what they really want. So I just want to give you a short insight what we already have. So now we have this online platform. So this is our website. So we have the looking for more section where we also have links. Also, the US is very, very prominent there as well. They have great projects. So lectures, interviews, and podcasts. And we also have this frequently asked questions section where we not only have written answers to these questions about body, fertility, and sexuality, but now we also have some in a video format, which already gives an idea to a potential answer. And of course, we also have a platform where also the survivors can ask their personal question. Then we have the share with others section where we have love notes. It's just short quotes, what survivors want to share, what was meaningful during the time, what did help them to go through it. And then we have survivor stories where you can click on, and then there is a picture of the patient, what they choose, and then can share the story. And now I'm very proud that we also start with a podcast, and I hope that you got this sofa without plush. So the plush sofa is an expression that you can see on the downside. So it was very fancy in the 70s with the hairy stuff, and when you sit a lot on it, then it is kind of smooth. And I was thinking of being bold, so as the association. And so this is our slogan is the taboo-free zone for young people with cancer, and here all your questions find their space. So this is Olivia, our survivor, and me. We are talking a kind of an informal conversation. We also interviewing patients so that they can share their concerns all around body image and sexuality and fertility. And the aim is there in a more of a informal way, answering questions, demystifying common beliefs, and share stories, and also to give the impression to not feel alone. And then we will start the Ask Force, which is more professional. So there we will invite experts and interview them and try to answer the questions, giving informations, and also introducing interventions. So yeah, I was in Hollywood, and I did now put the star. They just asked us, we are now also on the Walk of Fame, but of course, this is just a vision, obviously, and I think it all started with a vision. And what I like to bring as a message is, I think it would be great if you could go further to spread the word and improve cancer-related care by meeting the real unmet needs of our patients together. And I hope that we can work together. And so you will find more about it on our website. And now we are now on Instagram. So my take-home message is I think fertility preservation discussions are of great importance in pediatric oncology patients, but body image and psychosexual well-being should equally be integrated in survivorship care. And I think the main aim is to feel at home in our body in order to be able to open our doors for others and maybe to our garden. And I think I see ourselves as construction workers, helping our patients to rebuild their homes by defocusing from the potential dysfunction, but improving cancer-related knowledge and supporting resources in order to regain a positive image of the body, to strengthen self-esteem and to rebuild a safe and welcoming home again. So I thank you a lot for your attention, and I'm keen to answer your questions.
Thank you so much, Astrid. What an amazing presentation. So informative, and it's beautiful to watch this journey and to see the Just Ask Us project go from strength to strength, really. Congratulations.
Thank you.
I do open the floor to questions now. There's already a question in the chat for you from Mark Smith. What language is the podcast in?
Yeah, thank you for that. So, well, our website is in English, French, and German. The podcast that we just started now is still in German, but I am very much looking forward to come to Melbourne soon. And then I plan also to start the podcast in English.
That's very, very welcome news. That's fantastic. We've got a question from Carol Greenslade. Will this presentation be uploaded to this site? So I'm not sure if Carol's talking about the YouTube channel that we're talking about or to the Just Ask Us site. Carol, you might want to clarify.
Well, for sure, if you will give me the presentation and the recording, but because there are also other presentations from me and the others who are already uploaded there on our website as well.
Fantastic. So I have a question for you. How did you get the idea of founding the Just Ask Us? I just love what it's called. It just sounds so obvious, really. So what were you thinking when you actually founded this project?
Well, as I said, it was in 2017 when 2016 actually, anyway. So I did take over the GVH consultation, and then I did see all those patients after a stem cell transplantation, and then I was just, for the first time, I understood that we are always talking about fertility preservation. And we are just ticking the box and said, okay, yes, we did save their gametes. But then you see these patients in the survivorship, and then they struggle, and pretty much everybody had questions concerning relationship issues, their body, sexuality. And I was thinking perhaps it's because I'm a sexologist, and that's why perhaps I have a sign talking about sex with me. But then I was also going around, and then I was asking all the other clinicians dealing with cancer survivors. I was then going to the ESFP meeting and talking to you. That's how we met. And I was asking them, but is it really something that you think is really worthwhile having a closer look at? And it was overwhelming, really, to that all these other experts were confirming, yes, indeed. But usually we do not know what to say. And that's why I started the clinic first. And it was overwhelming, the patients and all the questions that they had. And then I was more and more motivated that I should then do something more, not only that you have to come to my clinic, but to reach out also those who cannot come, because there's a lot of appointments that you have. So to really give easy access to information and to share, and also to really give something that they can get back into their body, into their lives. And that's why I did found the project.
Thank you so much. I mean, I love also what you're doing with the building of capacity, spreading the word, building the capacity within the clinical community as well as, asking young cancer survivors to, ask the questions. It's a safe place. So I think that's really wonderful and really look forward to more learnings on this. There's a comment in the chat from Vicky Lehman, just no questions. No questions, but her compliments for this great presentation and the comparison of bodies and houses, which is really wonderful.
Thank you, Vicky.
So I'm just wondering, Astrid, what are the main kinds of questions that survivors may have? And do you see a difference in, prepubertal survivors compared to postpubertal?
Things. This was very, very interesting, because in the beginning it was mainly about fertility, and also age groups were rather older. But by seeing them, pretty much everybody was also then daring to asking questions about the sexuality. And I had some very impressive consultations where they said, finally, I now decided that I also have to take care about this issue. I did give up on it. And after 10 years, I had one who was like 10 years after a diagnosis said, oh, wow, I didn't know that. Yeah. And I just realized how important it is. And you give me hope that I can do something about it. And now I want to face it again. And then the prepubertals, it was my youngest patient was 8 years. And she was great. I mean, she was coming with her mom, and the oncologist could not answer the questions. So could not answer the question that she was okay with that. So she just wanted to ask further. And she had a little list of questions about, what about my ovaries, because they were frozen, and how can they stay, how long can they stay in the freezer? And will I be able to give birth, and etc., etc. So just to show you that also the prepubertals, they're very interested in fertility sometimes, of course, and about body image and sexuality. I think it really shows you have to address the topic on and on, because as probably you know as well, that the survivors, they are very often not as mature as their peers. So I see them very often more shy, and kind of really the milestones haven't been reached yet. So that's why also the questions that you would expect from a 16-year-old, from a cancer survivor, would potentially come later. And but I also had the peripubertal ones, like 14, 15. They were really keen on knowing about sexuality and first contacts, and how can I show my body to someone, and all these kind of questions. It's interesting. What is interesting is I did give a workshop for parents and survivors, and I was expecting the survivors to ask questions more about sexuality and the parents more about fertility, but it was the other way around. And it was really, really interesting, because the parents, they were keen on knowing everything about sexuality, because they said, wow, I'm overwhelmed because I know this is a topic. My boy now, he's 16, and I know probably it will be something that I have to face, but I do not really know how. Mm-hmm. And it was really interesting. So I wasn't expecting that.
That's so insightful, really. And it's nice to know that actually parents are really engaged in this, as they actually have been in fertility as well, and that these are conversations that we should start exploring with them. So there's a couple of more comments in the chat. So Timothy has said, thank you for your presentation. I'll share the website with those who view. Actually that raises a question. So you have this website, and is a vision eventually that patients from all, from wherever. So can my Australian patients access this website? And, is the content going to be adapted for, a variety of settings?
Sure. Well, we are very open. I mean, up to now, I have to say that it's not that easy to spread the information that we exist. So we really try now through social media to be more aware that get the awareness from survivors, because up to now they do not seem to be that interested. or because now we just rely on the doctors to give them our flyer. And so we just hope that they will get, especially with the podcast as well. So yes, we are absolutely open. We are very interested in also reaching out towards the US or Australia or wherever over the world, and to share, and also, of course, to answer questions, and survivors are more than welcome to give us inputs, what they need, what they would like to listen to, what questions they have. So yeah, I hope I did answer the question. And of course, I would love to collaborate. I mean, it's not that I said, okay, this is the only page that should exist, and also projects and workshops. I think it's important to work together, especially when it comes to communication workshops. I think it could be very beneficial to develop something together, and also then doing research with it to really prove that this is important. And I'm thinking practical workshops, yeah. Mm-hmm.
Yeah. And in fact, Timothy's mentioned a website, www.porf.org. So as an Australian, I'm not too familiar with that website, actually. So Timothy, did you want to tell us a little bit about that website? I'm not sure if you can unmute. In the meantime, I'll go to Lorraine, who has also said what a marvelous presentation. And she'd like to ask about the management of AYA patients from the sexual diversity viewpoint.
I think this is a very, very, thank you for the question, and kind of a comment actually as well. I think the sexual variety and cancer, I think is a very important topic. And I am very much looking forward to meet now Tanya in Melbourne as well, who's very engaged in the topic. And also the coming out through cancer diagnosis. This is an important topic that we also want to approach. So I think it is again, very important to be aware that the sexual identification or the coming out when you feel that, I mean, it is very difficult as such to admit potentially to a parent that you're homosexual or that you're a transgender or whatever. So I think this is already really, really hard. And then when it comes to cancer, you are so dependent on your parents. You do not want to disappoint them on top of having a child with cancer. And she did develop also a very beautiful booklet of information. And I think this is very important that they know that there is support. I think it's not a one-fits-all solution again. It only goes through personal contact and guidance. And I'm also involved in transgender fertility preservation without cancer. But in this community, I think it is again, very important that they know where to go to. But I cannot give the answer just like do this or that. But I think there exists more and more material on it. So the Peter McCallum Cancer Center has this booklet already, which is very helpful. And I hope that we can do a good job as well and include that in the future as well. Thank you.
Absolutely, a very important point. So when we see a young patient who's just been diagnosed with cancer, we're asked to consult them, do a fertility preservation consult. At what stage do you think we should be asking questions about sexual health, sexuality? Should that start from the beginning and right throughout the cancer journey? Or what do you recommend?
Well, first of all, I think we should really try to train nurses, so those who spend a lot of time with the patients, most of the time, much more time than we do. And there is very often also this close relationship with the patients and the nurses, because I think I would not ask directly upfront a screening question when he or she did just get the diagnosis. I think this is not, at least not if this is not an obvious topic or problem that they face. So this is more I think this is more for the survivorship or during the treatment. So I think it is important, at least for those who might be sexually active, at least to ask if they have a partner, because then it is important also to let them know about contraception, and that they can have sex under certain circumstances. It depends, of course, of the chemotherapy, etc. But I think it is still a worthwhile question to ask if there is anybody on the horizon, as you always frame your question when you talk about relationships. I think it is important to know if the patient is in a relationship or is sexually active. And this is already just to give the information about contraception, and then perhaps it might be an initiation to other questions.
Yeah, that's very, very useful. So Timothy has replied. PORF is the Pediatric Oncofertility Research Foundation, serving as a link between parents and pediatric patients and caregivers. They also fund research in pediatric oncofertility, and he would love to discuss ways that you might work together to support ongoing research. So thank you so much, Timothy. And Astrid and Timothy, please, share contact details.
That's great. And I think I do not want to say that there is nothing out there, but I did do a lot of research. I did really scan pretty much every website that I could find to support these young adults and adolescents. And usually there are some sections about sexuality, but what I always find, or very often, is, okay, you might face some sexual problems, you might face some vaginal dryness. In case, it's just one sentence, and then in case, ask your doctor. And so, and I think this is the problem. I think it is then you're stuck with a problem, because you might not dare to ask your provider, or he or she is perhaps not the one that you should talk to. So that's why it did come my idea to just give a platform to answer to this question in a more detailed way. And yeah, just another comment.
That's so interesting. Can I ask, where to from here then? And what are your plans for the future?
Well, well, of course, my dream would be, of course, that we really improve in general, the care about these topics, and also the awareness. And especially what I would love to do is, again, to start these communication workshops. And I think the communication workshops, because I know that Sharon Bogle, for example, I know from her that she did that already, but this was in the adult setting. And when I give my presentations to nurses, they are very interested, but they do not know how. How can I really, in practice, when there's a patient in front of me, how can I then deal with the reaction? How can I really lead the conversation? That's why I think there is a big need to give practical workshops where they can then train, because in my training to become a sexologist, I was also very overwhelmed sometimes, said, okay, wow, I'm an open person, but it's sometimes already difficult to start. How can I start? What could be a good question? And so to really give them tools and also go through the most embarrassing situations that they can ever imagine. And then they will also learn that they are not that embarrassing that they think they are. And I think by this, we can really lower the barriers and invite them to really start the conversation. And this would be my dream, to not only do it here in Switzerland, but perhaps that we could work together and do it in a broader setting.
That would be absolutely amazing. And I just want to share with the audience here that when Astrid first came to the children's, and I'll never forget a time when she was sitting with me in a consultation, and a young patient asked, quite a personal question. And I remember when, I was responding, but felt I could do a better job. And I turned to Astrid, and Astrid just slipped in and was able to just carry that conversation so beautifully and so gently. And I thought that's really a skill that, providers must learn. Of course, we're not going to be as expert as you, but, you know, in our own way, when the time is required, you know, we'd have a way to respond.
Thank you. I remember the situation, but it is not that I'm, you know, I'm not the one who knows everything. But I think it is, it's really my message. And I think it is not about to become a sexologist, but there are some tips and tricks. And I think it is more to be yourself, respect your limits, and then be authentic, and then to become and learn how to respond. And the more you do, the better you get.
That's absolutely right. I think the importance of just being yourself and understanding, you know what you understand, you know, and being okay with that, accepting that, and not having to have all of the answers, you know, in the consultation in the one go, just like we approach other things. But perhaps in these new areas, we might feel that we need to provide something that we don't quite know. And I think having resources like your website would be really quite useful. So Timothy has said, you know, I agree. Our experience is that clinicians are most reluctant to broach the whole topic of oncofertility, and he's provided his email address and contact details as well. Thank you so much for that, Tim. That's great. Does anyone else have any questions that they'd like to put into the chat and ask Astrid?
Can I just give a little anecdote? Well, it is just because reminding me of Melbourne, because I know that how nervous you were that I did give a talk at the children's about sexuality. And I know that how you did remind me, Astrid, you know that we are here in Melbourne. We are not in Europe, okay? We can, you know, you talk about sex and it might be, you know, please, yeah. And that's why I did think of how can I do this without making anybody feeling embarrassed. And that's why I did come up with a metaphor. This was, you know, it was because of you. So I just tried to talk about sex without talking about sex, actually. And it was interesting because then afterwards, it was amazing to see how people were just talking about their gardens, you know, about their plants and making fun. And I think this is just also a way that you can enable patients or persons, I mean, to talk about sex without really naming the hard words, and inviting them into a discussion in a way that they still feel comfortable, but you can still start talking about it. Yeah.
Thank you for sharing that and raising that. That was a very memorable time. And, you know, the whole organization really appreciated, you know, your visit and your insights, you know, and your expertise, you know, and we're growing along with you, which is fantastic. Lorraine has said, thank you very much for sharing this core topic. And, you know, it definitely is a core topic and something that really does need to be written into survivorship protocols, you know, in a bit more detail than what we've been doing, you know, as something that just should be undertaken. So I see that the time is 5:54, so it's close to close. So if there are any more questions, I'm happy to take them. So again, Astrid, thank you so much for attending this consortium and giving this webinar full of insights, and just the way that you talk about it is just so, I don't know, it sort of breaks down the barriers for all of us, I think, which is really wonderful. Thank you so much, Mahmood, for giving us this opportunity as well. It's you know, it's lovely to hear Astrid in this setting, and also to host this talk with her. So I think it's close to the end. So thank you so much. Thank you everyone for attending. And we will see you next time at the next webinar. Thanks everyone.